So anyway, I'm delighted to welcome George Hripcsak, who I consider a mentor, a friend, someone who's sort of guided me since 2010 when I started out in this journey trying to analyze EHR data and make sense of it. The general rule is if you think of doing something with EHR data, search PubMed with that concept and George's name, and you'll probably find a paper you should read before embarking on that. I think he also has the longest running NLM grant on making sense of EHR data warehouses. He's the department chair of the Department of Biomedical Informatics at Columbia, which in closed doors, I will admit, is one of the only two places we ever lose a student to in our own recruitment. And he's also the sort of the public face of this collaborative called Odyssey, Observational Health Data Science and Informatics. And our clinical data warehouse's backbone, the OMOP Common Data Model, is something that was created by the predecessor of Odyssey and then adopted and scaled and made better by this open source community, which last I checked was at least 100 different sites and 600 million patients worth of data converted into this one data model for reproducible research. And so with that, I'll welcome George. He also happens to be on an external advisory board for the CTSA. So his thoughts carry a lot of weight, and the floor is yours.
Thank you so much, Nigam, for the kind introduction. And it's been really fun working together all these years. And we lose plenty of students to Stanford, so don't worry about that. You guys have a great program. All right, let me start sharing my slides. There, and okay, just confirming you got the right one.
It looks great.
Yes, we see the slides.
Okay, great. All right, I'm going to be talking about Odyssey, including some discussion of using Odyssey specifically at our medical center, Columbia University Irving Medical Center. I have grants from NIH and FDA, no other disclosures right now. So I'll kind of give an intro to Odyssey for those of you who might be new to it, and I'll go over some recent evidence we've generated, some news about Odyssey and collaborations. I'm going to give a little bit about a talk I gave to ONC, Office of the National Coordinator of Health Information Technology, last Friday, because some of the recommendations there are actually relevant to medical centers also. And then talk a little bit about using Odyssey at Columbia, specifically to support services, kind of like what we've been talking about so far this morning. So observational health data sciences and informatics, his mission is to improve health by empowering the community to collaboratively generate evidence that promotes better health decisions and better care. I read that for a reason that you'll see towards the end of the talk. And Columbia University happens to be the coordinating center. Here's a map of our collaborators. Depends how you count, anywhere from 300 to 3,000 from 30 different countries, depending on you count by who actually put their profile in our website formally versus who just kind of signed up and contributes on the forums. We have records on about 600 million unique patients from around the world in a distributed database. So, you know, almost double the US population and almost 10% of the world's population. And what we do is generate evidence. You know, we often divide it into three classes: characterization, which means like counting things, then testing hypotheses, that's causation, and then also prediction, so precision medicine on individual patients. We're an open science effort, which is not just open source software, but everything. So when we do a study, the world sees the results before we do because we stick it on the internet and then we check the diagnostics with no one seeing it actually because they're hidden until we pass the diagnostics, and then everybody sees the data at the same time. That prevents us from cheating on data. How Odyssey works, so we have standards and tools and methods. How do you get 10%, almost 10% of the world population? Well, first of all, you start off, you keep it distributed. So there's a site behind a firewall. They keep their own data. They convert their source data into a standardized data using our standards and tools. Then we have a set of those around the world. When we want to do research, we generate a protocol. We distribute that protocol around the world. They download it from GitHub. They send up their answer, and then we collaboratively generate the evidence and collaboratively publish the papers. Probably preaching to the choir here, but whether it's between countries or within a country, the standards differ so much. And so, just saying, imagine if you're trying to plug in an appliance. And so the Odyssey OMOP Common Data Model, which I'll show in a moment, allows us to use a single plug and be much more efficient. So here's the data schema known as OMOP. So OMOP is Observational Medical Outcomes Partnership, which was the predecessor of Odyssey that Nigam mentioned. So when we went from OMOP to Odyssey, we changed our name, but we didn't change the name of our data model because we didn't want people to get confused or think it was a new data model, so we kept the old name. The point is that we try to keep it simple so that everybody can kind of understand it, so the tables are kind of approachable by new researchers. Hold on. Then comes our vocabularies. Again, we're processing data from around the world. Another summary is this: we have over 9 million concepts. So what we take is all the vocabularies from around the world and map them to a standard set, pretty much the US standard set from the Office of the National Coordinator, SNOMED, ARC-SNORM, LOINC, but we supply the mapping tables for all that. We also supply international resources. For example, ARC-SNORM, which codes all the medications, is only for US drugs. So Odyssey supplies ARC-SNORM extension, which is exactly dovetails ARC-SNORM, but supplies all the drugs that the US doesn't use. Those of you who have worked in standards know that even the same schema and vocabulary, same standard, 10 different people try to put their data into it, 10 people do it 10 different ways. So what we do is spend a lot of our time on conventions that explain how to use kind of the meta information of, if I have a death, a cause of death, like how do I code that? Because I can think of 3 places I might be able to stick it in that schema I showed you before, which is the right one. So there's a lot of work in trying to get us to not only have the standard, but use it in the same way. We have tools for preparing our data, tools for checking quality, tools for exploring that 9 million term ontology, and then building cohorts. A cohort is not just a list of terms, but also the logic around that. So saying, here's what needed to precede it, here's when it happened, here's the subsequent conditions. Then we visualize those cohorts and then use them in our analyses. And that's where we do research. Now I can go into an hour on each of these topics: the common data model, this on our tools. I think what I'll do for this talk is show a little bit of recent evidence generated. Let me first show you the 2017 hypertension guideline. That's the US one. 2018, the European guideline came out. It classifies about 58 antihypertension drugs into first and second line within classes. The circle on the left has RCT in the middle of it. That's the list of 58 drugs around the border. And the guideline uses randomized trial evidence. But there are only 40 trials. And if we look at individual drugs, those arcs where they're between the drugs is the evidence we have. What randomized trial evidence do we have for those drugs? But we made conclusions in that guideline about all those drugs. What we're really saying is that most of our guideline is expert opinion. Yes, it's informed by the randomized trials, but a lot of it is expert opinion that these 2 drugs should act similar because they seem to be within class, or it's a related class, or whatever. Odyssey said, we have all these data, why don't we try to fill in the gaps? So on the right, you see Odyssey, and it says, well, let's try to compare every drug to every drug. And in fact, it compared every pair of drugs to every pair of drugs, because in hypertension, you often use 2 drugs. And what you see on the right is what we filled in of evidence that we supplied. Skipping forward, these are the publications that came out of it. Actually, the Lancet on class-based hypertension, on beta blockers, JAMA internal medicine, on diuretics. The one on the lower right is actually about other cardiac research. It's kind of related, but it's not exactly that study. We mostly confirmed the US guideline, which is actually, according to our evidence, a little better than the European guideline, in that beta blockers really are second line, whereas the European guideline put them as first line. Some surprises that thiazide diuretics did better than ACE inhibitors, and that chlorthalidone did worse than hydrochlorothiazide. It's become popular to try to prescribe chlorthalidone because it's theoretically better, but in practice, it seems to do worse. I just reviewed another paper today that further confirms our result. in a previous result that be careful with chlorothalidone. So we've been, and this is just a subset of the data. So we've finally gotten from the stage of publishing papers about informatics and statistics to publishing papers in second-tier journals. That Odyssey's actually stepped up and now publishing papers in top-tier journals and having an influence. I mean, being in the medical letter doesn't mean you're necessarily influencing practice, but our evidence is beginning to show up in various places. COVID-19 hit, caused us to cancel our European symposium, which caused us to do a 88-hour straight codeathon to start addressing COVID-19 last March, about a little over a year ago. We've collected data from academic medical centers first. They were the first ones with data, then EHR and claims data aggregators and government databases, so that we have about 4.5 million COVID-19 patient records. And we carried out 41 studies in the past year, most of which are published now. Some of them are still under review. I'll just give a few examples. First, the safety of hydroxychloroquine. One of our studies was looking at safety hydroxychloroquine and using it in combination with azithromycin, and we found that there are risks for using it. It's a very safe drug, and for treating COVID, it would be fine, but as prophylaxis for hundreds of millions of people, you have to look more closely at the safety. The FDA doesn't say how they use their evidence. They just come to a conclusion. The EMA tells you what evidence they use to put forward a decision. And in fact, it highlighted as one of 2 studies that look carefully at hydroxychloroquine safety that they used in making the determination that hydroxychloroquine is probably not recommended for use in COVID-19, either treatment or prophylaxis. Another thing we looked at, people were worried about ACE inhibitors, actually ARBs also, about them causing, making you more susceptible to either being infected with or having complications of COVID-19. Our study showed that you did not. And again, the European version of the FDA, that is the European Medicines Agency, the EMA, used our evidence in that decision and in fact highlighted Odyssey and put it forward as an exemplar of a study that had good reproducibility in a sea of bad studies that were done in a rush for COVID-19, Surgisphere being one of the famous examples. And third, let me point out, and we're still active, so vaccine safety research, March 11th to 15th, 13 European countries suspended use of the AstraZeneca vaccine for fear of blood clots. On March 18th, the EMA determined, took a look at those reports. The rate of clotting in general was 469 cases out of about 20 million, which is actually lower than expected. But DIC and cerebral venous sinus thrombosis was a little higher than expected. So there were probably risks. They may be causal, but given the severity of COVID-19, they felt that the benefits outweighed the risks. On the bottom, the very bottom, you see that archive study. We actually gave our evidence over to EMA before that archive even came out. That figure there is shown. And that was actually the main, I believe was the main numbers they used as baseline rates for their determination that it was safe in general, although maybe risky on DIC for that, which led them to restart vaccination for tens of millions of people. We're also partnered with the US FDA, their Center for Biologics Evaluation and Research. They're the ones who do vaccine safety. We started off working with them on transfusion, but then pivoted to vaccine safety. And so we're doing methods work and also doing some network and local studies for them. A lot of groups use the Odyssey OMOP Common Data Model. Putting aside Odyssey does research on its database, but other groups. So the FDA actually adopted the biologics part of the FDA uses our data model in their program, separate from their collaboration with us. The All of Us Research program uses the OMOP Common Data Model. The eMERGE network uses Common Data Model. And the recent National COVID Cohort Collaborative, or N3C, also uses the OMOP Common Data Model. And we also work with PCORNet and Sync for Science and other groups. So now let me give you a few updates about Odyssey, what's going on. For those of you more familiar with Odyssey. So one organization, we're trying to, we're a large, sprawling, open science effort. Everyone is welcome. There's no cost to entering. So we're trying to organize a little bit more. You may know the objectives and key results, OKR, that Intel's leader, Andy Grove, had adopted, and then John Doerr made popular. Well, Patrick Ryan brought it into Odyssey, and we have all our work groups doing goal setting using objectives and key results, and we'll see how that goes to organize and keep track of how the community is going and perhaps have less duplication of effort. You may have heard about the HL7 Odyssey Partnership announced on March 1st. So HL7 uses FHIR, which is Fast Health Information Resource. I hope I have that right. So FHIR is the version of standard coming out of HL7 for clinical information that's become popular and being used by essentially all vendors and is being pushed forward by the U.S. Office of the National Coordinator. And of course, OMOP is our common data model. So what we've decided to do, the organization, this is from our press release, so I don't get it wrong, the organization will align their standards to capture data in a clearly defined way into a single common data model. This will allow clinicians as well as researchers to pull data from multiple sources and compile it in the same structure without a degradation of information. We're early in the creation of the joint working groups and scope. I meet every week or every other week with people like Graham, who started FHIR, and others and directors of HL7. And Christian Reich is the one from Odyssey who's really leading the effort. We started with existing mapping work, so Georgia Tech, Eden, Miricum, Leiden University, Denmark, are different mapping efforts between FHIR and OMOP. So the range of what we might want to accomplish is anything from, just pure mapping between the two, which is like a bare minimum. So second would be shared knowledge engineering, where like a new area opens up and HL7 has to go in there and learn all about it and the coding schemes and what schema makes sense and the protocol. And Odyssey in parallel is doing the same thing. So at the very least, maybe do one shared knowledge engineering effort as we go into new areas. And then finally, a single common standard, maybe it's one semantics with two syntaxes, maybe where we end up, as a hopeful thing. And, we welcome feedback on what we should be doing on the Odyssey forums. We haven't really brought in the group yet. We're doing a couple of small meetings between HL7 and Odyssey first, just to get started and to create like a core work group. And then we'll be inviting the Odyssey community, and HL7 will be inviting the HL7 community to really populate these the shared work group or set of work groups. We're doing a lot of methods research. As I mentioned, we're working with the FDA. One thing that we're almost finished this paper that we'll be putting on archive, baseline incidence rate estimation. Actually, we did rate estimation, and I showed you that earlier that the EMA used. But we're looking at specifically is the methods behind that. So if I'm going to say whether a clotting rate is high or low, I need to know, what am I comparing that to? Realize that if you look at something like myocardial infarction, a heart attack, depending on the age group, the incidence rate varies by a factor of over 1,000 between, say, a young person and an old person. Other things are affecting it. Well, when did you measure it? During a visit or just at a random date during the year? That can vary by, depending on your time at risk you're looking at, can vary by up to 100-fold. So depending on how exactly you measure those incidence rates, it can create numbers that vary enormously. And then you're doing some statistical test asking whether it's 1.5 times higher. Well, you have to get it matched right. We're also looking at different methods of deciding whether, when you have two rates, comparing them, self-controlled case series, cohort methods, historical control. So we're looking at those and comparing them with a big benchmark study. Completely separate from this, we're doing some research into using smaller databases with small sample sizes and rare outcomes. Our Columbia database is over 6 million people, yet every time we do an Odyssey network study, we're included in the study, but our data are often dropped because we didn't pass the diagnostics because our sample, because remember, I don't really have 6 million. Now I'm looking at diabetes, at this drug with this complication. Well, that number then goes down. So we're coming up with new ways of how do we benefit from the small databases. Instead of doing a meta-analysis across databases, for example, share not like, say, an estimate and its confidence interval, but share the whole likelihood distribution. so that more information is conveyed and we can combine them in ways that doesn't eliminate the good benefit of the smaller database. A lot of what we do is propensity score balance. That's how we get rid of bias due to confounding. That's something very hard to do in small databases. How do we share information from large bases to accomplish that? And those are actually examples of the last one, but we're diving deeper into causal inference, bringing in collaborators from other fields in computer science and statistics, helping us out. Well, I mean, Odyssey has a lot of statisticians, epidemiologists, and computer scientists, but reaching out even beyond that to advance in causal inference. A number of Odyssey centers. So Columbia is the coordinating center for Odyssey, but Northeastern University has developed an Odyssey Center at RU. RU is one of their campuses in Maine with a focus on education, but they'll expand and they'll be doing a lot of Odyssey work. Also, Erasmus University, so the European effort, created something called Eden, which is collecting data from around Europe and has a very large, like many, many millions of dollars grant to accomplish a database. And that's been an initiative, and they're turning it into an institute, which will effectively be another Odyssey Center. They're actually interested in education too, and the Eden Academy is where you can go for learning. So if you want to learn how to use some of these causal inference methods, you can go to the Eden Academy. Now I'm going to talk a little bit about what I presented to the Office of National Coordinator. Reading in retrospect, you have to grab people's attention. The message I'll be giving is not a message. Some of it is not a message I need to give to this group. But the first thing was objection to research being seen as a secondary use. Research is not an afterthought. It drives healthcare and saves millions of lives. Jonas Salk invented polio vaccine. No one remembers his billing records anymore. Without research, we would be billing for leeches. And we'd be doing it really carefully. We'd make sure those leeches are healthy and we were doing the right number of leeches, but of course we'd just be hurting people. So perhaps after patient care, research should become paramount and billing should be forced to make do with what else is available. So we need, when we develop standards, to make sure we cover research. For mission, I like to say, and this is important for groups like yours or our CTSA, you can either store data or you can generate evidence, but you can't do both. So what that means is your mission, if your mission is to store data, then you will end up with a data store, but you're probably not going to generate a lot of evidence because there's a million decisions you make when you store data. And if you're not focused on the use, you'll make decisions that make it hard to generate evidence. So your mission has to be to generate evidence. And then along the way, as a means to that end, you may store data, but you can't have it as the primary goal. So then going along with that thought is coupling. Therefore, you need a tightly coupled enterprise where evidence generation and standards development, that was for ONC, or evidence generation and for the CTSA group, infrastructure creation have to be tightly coupled. Odyssey does it at the governance structure level, where the people generating evidence are leading the thing for the standards development. By the way, standards is not just data standards, there are also analytic standards. And Odyssey recently published a paper in JAMIA, Journal of the American Medical Informatics Association, on something called Legend, which is our principles for how analytic studies should be carried out, observational research. The standard has to be connected to the community. It's helpful if we're open source. Actually, to be honest, we use some standards that are not open source, like for example, SNOMED is not actually open source. It's available to everyone in the US because our government pays. But these groups, and the AMA has a standard CPT that's also closed. These groups have been extremely generous with us. So when Odyssey goes into a country, we have freedom to use those standards for research, whether or not that country paid for that standard. They're not supposed to use it for clinical care without paying, but Odyssey can use it. And it's a simple click through to say yes when you go in, and that's all you have to do to use those standards. It's not magic. This was motivated because FHIR, the standard I mentioned earlier, is moving into areas like not just sending information for individual patients, but doing it on all patients at once. That is a fire dump. Dump all your data out of your electronic health record into a data store. And with that is a promise, and perhaps a false promise, that, well, if I can just dump the data out of every electronic health record from every healthcare provider, I could stick that in a central data warehouse with proper permissions and protections and do great research. The problem is there's a data quality price that has to be paid no matter what. Columbia actually helps run the All of Us research program data and resource center, joint with with a subcontract from Vanderbilt. And we actually do the EHR, electronic health record data conversion for the effort. And we find that the conversion is best when it's close to data generation. So even if you can dump data to your health record, that doesn't get rid of the data quality price that you need to do data quality assessment. And last, pushing on the standards to ONC. The US is 5% of the population. Continued focus on US only standards hurts US citizens because modern causal inference is data hungry. We can't answer most questions with US data. We have to go outside to enlarge our sample size. 5% of the world's population sounds like a lot, but again, when you pick a drug and a disease and a side effect, by the time you get down, you're down to tens or hundreds of patients, which may not be enough to do some of these algorithms. And finally, I'll talk a little bit about using Odyssey at Columbia. Karthik Natarajan, these are his slides that he gave to me. So here's the Odyssey ecosystem. So this really goes back to my earlier slides. We have the ETL tools, data quality tools, and the study design and execution tools. So this is kind of the Odyssey stack that you would install at your institution if you want to exploit Odyssey to do local work. We've made the Odyssey tools broadly available. So what we said is anyone who can get to the electronic health record can get to the OMOP, our OMOP database using the Atlas tool. So what we do is we de-identify that. So we have an OMOP copy that's not de-identified that we use normally for our large-scale Odyssey research network studies. We have another copy that's de-identified. It's only refreshed 1 or 2 times a year, but for this purpose, the other one's refreshed more often, but this one's refreshed 1 or 2 times a year because we have to be extra careful about the de-identification, and make that available to 15,000 users via our electronic health record. So they go up, hit explore, and they're in the Atlas tool set where they can build cohorts and explore them. The only downside of that is people like the Atlas interface and they want Epic, which is our new clinical information system, to have the same displays, which of course Epic doesn't have, but that's okay. And then we do data consultations and other things. Then we have another version of this database, which is also de-identified, which we make available in the department, say for our PhD students who don't have access to the clinical information system. So they go through another path. That allows our trainees to also have access to a database that we think is safe enough for them to access. Some of the bad news, well, we have, security constraints. Atlas is an open source tool. So we have to work on Atlas and install the security things that we need so that it can use Active Directory and make sure it can't be broken into and other things. So we have to do that conversion. So we're generally 2 minor versions behind the current Atlas version, which is frustrating for people who want to use it easily, but that's what time it takes us to install the security tools. Documentation, we just use a Confluence. There's the Odyssey documentation. There's also the Columbia specific documentation. And then we have we're almost done. We also have our data lake with the OMOP, but then we also have our old CDW, which we haven't decommissioned yet. And then we have another place where we stick notes, and we have custom tables, ancillary systems. And like you, we have our external databases, which should be marked here, but say market scan and things like that. We've made these tools available, and the hospital, New York Presbyterian Hospital, actually uses it. So one of the things we do, embarrassed to admit we have to do this, US News and World Report, reports that go to them. which used to waste a lot of our times. It would take 8 weeks to do some of these with a large number. Actually, we're not showing here's the number of people, like 40, 30, 40 people. So we're now down to doing it in 4 weeks with 10 people instead of 8 weeks with 30 people. And this is an example of it. So I'll skip over that. Actually, this is the last slide. And then last, just to mention Columbia as data consult service. So thank you to the Stanford Green Button team for the insights and help and leadership. Our version of it is run by Anna Astropolitz, who's actually my PhD student. It's a research project. You've gone into production. We just have a research project to look at the effect of real-time evidence generation. Brief summary, we've done, at this point, we had done 29 questions from 22 clinicians and able to give 24 answers. It's largely from internal medicine, but that's because the IRB first had us recruit through a snowball thing. So we had mostly internists in the department. Most of the questions were about recurring issues, but about a fifth of them were about a specific patient. Well, I have a patient here and I want to know right now the answer to this question so I can treat this patient. One of them, which is not included in this list, but for the prototype question was, does penicillin cause angioedema? The answer is no, or not usually. It could, anything could happen, but I think they had caused angioedema and wondering if they should stop the penicillin. The challenges we've run into is missing data, underreported conditions, condition coding, drug regimens. We do a full analysis that's just as rigorous as any of those studies that were published in Lancet or JAMA. It's one person, so sometimes it's, we can sometimes do one of these studies in 2 days because the person running it is so accomplished at all that she's a doctor, intern, informatician. But so those are our results, and we're kind of assembling more of that, and we'll be publishing that hopefully soon, submitting that. And I think I'll stop there and just end on the Odyssey website.
All right, thank you, George. There's a couple of questions. This one is from 2 minutes ago. Did the hybrid approach refer to the use of identified and de-identified data, or was that something else? It's a clarification question. So given the
hybrid,
timing,
what did I do I can't remember why I said the word hybrid.
So I think that was at the time when you were showing the use of the data warehouse by the quality reporting team for the new US News. I think that was the hybrid that operational and researcher teams and clinicians all can use the same version.
Yeah, so what we do there, so we have, just so you know what I'll probably be answering a different question, but that's okay. We ended up with several versions of the OMOP database depending on your role, but if you're doing research or operations, we use the same OMOP version, which is the identified version. The de-identified version is just for people so that they didn't have to go through such an IRB process. They don't need IRB. I am PI on the IRB approval for them to do their research on the de-identified version. So that's one version we have. And then we have a separate one for the PhD students just because it's really more mechanical than anything. But the research and operations, they actually do it using the same tools on the same identified data set.
Got it. And just for our audience here, we host our OMOP CDM on BigQuery. We refresh it every week, and the same version is available to everybody. Clinicians, faculty, researchers, students. You have to go through the Nero system, but everybody's looking at the same data. No copies, same version.
Okay, I see some of the questions. The notes are not part of OMOP. OMOP has a notes table, but it's not that useful because the tools don't use the notes. So we just happen to have them. They may actually be in there now, but when I do research, I use it on another database. What we're putting into OMOP now, Carol Friedman is parsing all the notes we've ever done, and they'll be put into the structured tables as the parsed output. It's a data lake, so we have like 4 versions of the notes, to be honest.
Priya, do you want to comment on TIDE and what you and Jose have done? You're muted.
I am going to talk about it in my presentation.
Okay, perfect. Perfect. So the notes and how we manage them at Stanford will be addressed in the upcoming presentation. All right.
Very briefly, but yes.
There's another question. Is there a local data dictionary for our local OMOP that translates to more common clinical terminology?
Well, so I think it's to you, but to us, the Odyssey tool, well, it depends on what you mean by common clinical, but remember that it has every vocabulary. So if you're used to ICD-9 or ICD-10, that's right in the tool atlas. If you mean synonyms, it's in there to some extent. The standard synonyms are in there that you can look for words that way through the tool that you use to find the words to create concept sets to create those cohorts to do research.
Yeah, I know, knowing who the person asking the question is, I think the short answer is yes. You might want to look into the source vocabulary columns in the CDM to get to our common terminologies that we use. One more. What are the time plus people resource estimates of bringing a new partner on board the network? Example, an Epic EMR instance, assuming their leadership has signed off.
Well, the first version of an OMOP database is a full time for 2 months for a good analyst. But that's an underestimate because at the end of that, you start using it and you realize how come there's no asthma in 2005 or something. And then you go look and you realize all the things that went wrong along the way, some of them with your conversion and some of them with your original database. A lot of people actually benefit, not even without the OMOP database that comes out of it, but just fixing the problems they found when they converted to OMOP. Our team, usually you have 1 or 2 people working full time, continually improving it over time and updating it. You could have, if you're doing some code development with Odyssey on the network, you might have 6 people, but that would be big. I think most people have 1 or 2 people and they get their version up in 2 months.
All right. And there's also a rich ecosystem of vendors who, for a fee, can help do ETLs without having your local staff. So I know the person asking the question, happy to share what we do on our campus as well. All right. We're at time, or 60 seconds over. I don't see other questions unless I've missed something. I think, yeah, we got the notes, we got recording questions, hybrid. Yeah, I think we got all the questions. So thank you very much, George, for spending time with us. You're most welcome to stay on for the rest.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.